So hi everybody, my name is Shauna. I'm a palliative care nurse practitioner at UMass Memorial Medical Center, and I'm also a Shrewsbury resident, so I'm very happy to be here today. And this is some of the members from our palliative care team, so I'll let everybody introduce themselves.
I'm Wanda Michael. I'm one of the physicians and Associate Chief of a division at UMass.
I'm Nancy McCool. I'm one of the palliative care social workers.
And I'm Jennifer Reedy. I'm a palliative care physician and the chief of our division at UMass.
And this is some of
The rest
our
of our
other
team.
division members up there. We're missing a few of them.
So these folks are physicians, nurse practitioners, social workers, and we have a music therapist now as well, a pharmacist, our administrative assistant. So we are an interdisciplinary, meaning we have different expertises that we bring together to take care of the whole person and their family.
So before we get started and talking a little bit more about what palliative care is, I was curious to know what you know about palliative care, and also, what you're hoping to learn here tonight.
Okay, if I may begin.
Yeah, sure.
I mean, I've read Atul Gawande's book in which he lists some 8 or something, I don't forget the exact number, of things that an elder person should do. And I'm pretty close reaching that age. But having said that, I don't have a long-term insurance plan. I don't believe in living in fear. So what I'd like to know is, God forbid, if I'm not able to meet those criteria, what are the resources available to me in the community that I can get? I mean, at the community, I mean community and UMass, which is the nearest medical facility, is number 1. And number 2, how much would I need to keep aside should I get into one of those problems without a long-term care? If I were to request a nurse practitioner or somebody to come to help me fulfill those 8 obligations, dressing, eating, bathing, walking, and something else with us. So if you could just highlight that so that I can plan for my future and my old age.
Can I just ask you a question, though? Just follow up the question. When you say, I don't want to live in fear, can you speak to that a little bit for us?
Yeah, so what I mean is, for anything and everything, there is an insurance. You book an air travel ticket, they say, oh, get this insurance, just in case you cancel that. And just for everything, there's an insurance. Maybe if I walk 10 feet, oh, you may fall, you may get hurt, get an insurance. No, I don't want to be doing that. I mean, I just want to lead life like a normal human being without being told that I need to insure for every single thing. A day might come when they might tell me, oh, take an insurance because maybe you're not saying the right things.
Right.
This is not acceptable. So the insurance will cover you for any rubbish that you speak. So I don't want to get into that kind of a future. I want to be in a future where, I don't do anything antisocial, but I'm still free to do what every other normal human being would do.
That's a great explanation.
So I'm hearing that issue around practical supports at home, helping people maintain independence, dignity, quality of life at home. What kind of things are available?
Sure.
Strategies, is that right?
That's correct.
Okay.
We call that aging in place.
Yeah.
Right? Have you heard that term before?
Yes.
Aging in place. What's a good way for you to figure out how to age in place? What things you need to put in place for you to be able to do that?
Sure.
What
Yeah.
were you saying?
Yeah, exactly.
Okay.
Exactly.
I just want to ask a big word, what does palliative means in a nutshell, because it's people with the medical knowledge, they might know, but I think for the layman, what does that mean?
That's a good
We'll
question.
definitely cover that in just a moment.
Thanks.
So I'm here as the chair of the Friends of the Library to certainly support the program, so thank you for being here. But also thinking I was able to nurse my father and keep him at home until he passed away. But my mother was there as a support. But she's in her mid-80s and thriving at the moment. But certainly getting up in years. So I'm starting to think a lot more, because I know that that will be primarily on me, you know, when she gets to that stage. So trying just to be cognizant of, you know, what resources there are and, you know, how I can help her through that process.
Right. Kind of a corollary to what you said.
Right,
Yeah.
from an elder care perspective.
From a caregiver, yeah.
Yep. Yeah. Great. Brandon, do you have anything?
Yes, as doctors and healthcare professionals, do you ask those questions of patients that Dr. Doula mentions in the book? I mean, when they have a terminal illness or when they are in palliative care, do you ask them, you know, what kind of life they'd like to lead and what they want? And are you able to fulfill that or help the family fulfill those wishes?
All great questions.
Absolutely, that's a very good question. Yes, it's a big part of our mission, for sure. So yeah, that's a good segue into Shauna's going to describe palliative care.
Yeah, so palliative care is a medical specialty that focuses on people with a serious illness and helps them improve their quality of life as much as possible by treating symptoms associated with the illness, but also supports people and their families as they go through the stresses of the illness, and helps with practical things like supports them leaving the home and different resources and things like that. And palliative care can be given at any age and any stage of a serious illness, and it can be provided along with curative treatment. And so we look at it as it's an extra add-on support for somebody with a serious illness. And we work with the caregivers that you already have to make sure we're delivering the best care that's in accordance with someone's goals and values and beliefs and what they are hoping to achieve. So that's kind of palliative care in a nutshell.
So when you say serious illness, what do you, what kind of illness do you put in that bucket?
So there's actually a growing consensus about that very definition in our field. So a serious illness is a condition that is life-threatening or life-limiting. So that includes a lot of different conditions, as well as impacts the person's functioning and quality of life on a daily basis, and or causes stress, significant stress for their caregivers. So that's the definition of a serious illness. So you could imagine how that applies to a host of different diseases, like advanced cancer, advanced heart disease, kidney disease, liver disease, neurologic diseases like dementia, or also folks who have lots of different health problems who are older and becoming more frail. So it's a pretty broad definition, but we're really talking about a condition that's life-threatening or life-limiting. Now, you brought up, Priya, about, just to add to what Shauna said, a big part of what we do is conversations. So we do a lot of family meetings, we have a lot of heart-to-hearts with people with serious illness and their loved ones to really hear, to kind of help make sense of their medical situation, you know, pull together the different pieces of information and make sure people understand you know, the medical facts and kind of what they're facing and their understanding of it, but then learning about the person, you know, who they are, what matters to them, their values and their goals, and what makes life worth living for them. And then our goal in palliative care is we want to weave those stories together, the medical story and the personal story, and find a plan of care that makes sense based on that person, and to find a way forward in often a difficult circumstance. So that is very much the mission of palliative care. And Dr. Bawande writes about that very eloquently in his book as well, from a personal standpoint as well as about the stories he tells about patients.
So do patients make the choice, or do their families make the choice to go to a palliative care specialist, or do the doctors who treat them for the disease or the primary care or somebody else refer them to?
Yes, there's multiple ways to find palliative care. Wanda, do you want to answer that?
No, there are multiple ways to access palliative care. So Obviously, you can get a referral from your primary care physician, from any of the other treating physicians, if you're seeing a heart specialist, if you're seeing a cancer specialist, if you have a lung specialist. So if a person is getting to that stage of illness where it's getting into the definition of serious illness and it's really impacting your life, you can get referrals from anyone. But a lot of times we do get referrals from patients and families themselves. They request their physicians that they would like to see a palliative care physician, and that they want to have more conversations in depth about what's to expect, what are the next steps, how do I make sure that I live at home in the best way that I can. So it can happen both ways. And palliative care can be delivered at any place. So obviously we have inpatient presence in the hospital when somebody is admitted, and they can request a consultation from a palliative care team that's providing care in the hospitals. Is in the clinics. So we have, just like any other regular clinic from the primary care doctors or specialists, there's a palliative care clinic, which is at UMass is available for 4 days a week that you have the presence of a provider in the clinic. It can also be delivered in any of the community or the nursing home rehab settings. So that is a growing branch of palliative care where it's delivered in the community. So we try to get to people where they're at so that they don't have to have that burden of coming to the clinics. But it can be given at any place that somebody is present.
We are definitely a newer field of medicine, so, as Dr. Nagpal just said, palliative care really kind of came of age first in the hospital setting. And, a lot of times in the hospital, we're seeing people in crisis. This medical crisis and emotional crisis, and it's often a turning point in their disease. And we do that work every day, but really we want to be able to find people and serve them better outside of a crisis, and ideally before a crisis. And so we are now, as Dr. Nagpal said, we have an outpatient clinic, but we're really trying to find strategies to build a team, ideally in the community, that could go to people's homes, nursing facilities, assisted living. And in my hat as chief of the division, I'm always looking for ways to try to figure out how to make that work. So those are the things that we're actively working on right now. So we know the different partners that we have in the community right now that are doing some palliative care. And so we do a lot of connecting the dots. We're very aware of all the resources that are there to help people try to tailor a plan of care for a patient and family that makes sense. And Nancy, our social worker, is the expert of things like that because she knows all about the different resources.
There are a lot of resources available. Actually, I think the people in Worcester County, especially this area, are really very fortunate because UMass has a big palliative care team, inpatient, but also an outpatient clinic. And that could be accessed, like Dr. Nagpal was saying, through a referral, but also it's a great conversation to have with your primary care doctor. If you have any thoughts or concerns, or kind of what are they thinking? What are their thoughts about palliative care? There are services like Elder Services in Worcester is a great resource, and they are just a phone call that it doesn't cost anything to call them to say that this is what you're thinking about and what would that look like for you, and to bring somebody there, depending on the kind of resources that you're looking for. I also think it's a good idea to talk to a financial counselor to find out, when you're going to retire, where you want to live, what you want to do, how much do you think all that's going to cost. I mean, I don't have long-term care insurance either. But, so not everybody ends up in a nursing home, but what would you do if you needed some money to help you stay at home? They can help you figure that out too. And it's very good. I think it's wonderful that you've all come here to have this discussion because, like Dr. Reedy was saying, we love for these discussions to take place well before you need any of that stuff. So it's not a crisis situation, it's something that you can act and not react to. So I applaud you for doing that.
Since we're on the topic of community resources and practical supports, maybe we should just address particularly the the very important issues two of you raised for ourselves and for our loved ones, if we're thinking about how to be proactive and think about planning how to age in place and have quality of life. You know, I wish there was a good magic wand to have that all put in place, of course, but it's not, and it looks a little different for everyone. But I will say, we accompany people into that space all the time, that especially when someone does have a serious illness and they are having more trouble caring for themselves, it often, honestly, not only becomes a personal crisis and emotional crisis, but a financial crisis, where we see people in the hospital and then, let's say, they really can't manage at home anymore. And you're probably aware that in Massachusetts, if someone can't live at home anymore and they don't have loved ones that can be with them 24/7, and or they aren't able to, say, privately hire caregivers to be at home, then going to a nursing facility means that Mass Health or Medicaid in Massachusetts will pay room and board for long-term care, but that means someone has to qualify financially for Mass Health and apply for it, or pay out of pocket. So those are, we see that all the time, and it's sort of it's so utterly common, it's really kind of shocking that we don't talk about it more as a society, because it's really a very huge burden on people. And so I completely agree and applaud, for thinking ahead, because truly, again, the options are for nursing facilities, it's either out of pocket or Medicaid, or if someone has long-term care insurance, which those can be expensive, but some people choose to purchase them. And long-term care insurance, and you can correct me, I got Nancy here next to me, tell me if I get this is a test, that some long-term care insurances you can pay for private caregivers at home for a lot of these policies, so you can kind of flip that costs to doing in-home care. But then, without long-term care insurance, people pay out of pocket to have privately hired nurse assistants or LPNs or even RNs at home, and it's a lot. If someone has Mass Health, Medicaid, they can have what are called PCA hours, where a loved one or a friend or someone can be hired to be paid under Mass Health to care for someone at home. But again, that's only if you meet the financial eligibility for Mass Health.
Which is very low.
Very low.
Almost like $1,000 a month, and
Yeah.
maybe $3,000 assets, something like that. So average people, and especially Shrewsbury community, I'm talking about not average, but I think it's a rich community, so to speak,
Right,
intellectually as well as financially.
right,
So that option is not really available,
right.
most likely for everybody who is sitting in this
Right.
room. So
Right.
what's the alternative,
Right.
And
It's
I
paying
mean,
out of pocket or long-term.
pay out of
insurance.
pocket, and
That's the reality,
yeah.
unfortunately.
And long-term insurance premium is not cheap either.
Exactly.
But-
Go ahead.
But by the time you add some of the adder, like inflation rate, various things,
Yeah,
it could cost you anywhere from $5,000 to $10,000 probably. I think even a month or something. So it's a long-term care insurance is very, very expensive.
That's what I've heard. It's evolved. It used to be when you bought long-term care insurance, it was for if you were going to go into a nursing home, it would pay for you to live in that nursing home. But they found that that wasn't sustainable.
Yeah.
And they weren't really making any money off that because people were living a really long time in nursing homes. So now, what it's really for is a supplement. To give you, it's not to pay for your entire care, but to give you, maybe $1,000 a month or $3,000 a month so that you can pay for caregivers to come and help you. Because if you have Medicare, it doesn't cover any kind of custodial care or caregivers. So that's really, for most long-term care insurance now, that's what its purpose is, to supplement whatever other things you have going on.
So can you talk a little bit about what generally is or is not covered under a long-term insurance care program?
You know, they're all so different. Some of them will cover a nursing home, some of them won't, some of them will cover care at home, some of them will cover all kinds of other services. They're really all different. You would have to check into each one or go to an insurance broker and say, this is what I'm looking for, or this is how much I want to pay.
Plus, I think those insurance, long-term insurance are not forever, not for your lifetime. It's depend upon policy, something like it will only cover you for 24 months or
Right.
36 months,
Right, we're not-
something like that. And I think average people living in nursing home will say is no more than 2 years, I guess. So, I mean, there's a lot of things, actually,
Yes.
consideration is taken in
Yes.
all those things. But something what you explained for small thing to subsidize, I don't think there is any insurance available for those kind of things, is it?
You mean for the?
Like $1,000 a month or something to take care of certain palliative care.
I think it really depends on what kind of insurance you have and what kind of a policy that you're looking for. So it's all, you really kind of have to talk to like an insurance company to find out what, some people want
Some
24/7 care in their home. Other people don't need that, they just want a little bit of someone to show them. So can you use some of the money for some care and use the rest of the money to put in a stair lift? You know, it depends on the policy. Some people might allow that, some people might not.
So welcome to a couple other folks that just joined us.
Welcome.
Hello. We're the palliative care team at UMass Memorial. We're the palliative care team from UMass Memorial. Nice to see you. What's your name?
Devorah Caspi.
Laura, nice to meet you.
Thank you.
Hello.
Hi.
Hi.
Well, my name is Vikram.
Nice to meet you. So, just to repeat our names, I'm Jenny Reedy. I'm a palliative care doctor. I'm the chief of our division.
I'm Nancy McCool, I'm the palliative care social worker.
And I'm Shauna Stegman. I'm a palliative care nurse practitioner.
And then Monica Lightball, I'm the Associate Chief of the Division and Physician.
We're just doing kind of an overview of palliative care right now, and we went around and people shared why they're here or what they wanted to learn about. And we're talking a lot about practical supports that people can have at home as they age, or if they're caring for a loved one as they're aging, and what's available. So we've been doing a bit of talking about financial stuff, believe it or not, which is a big part of all of this. I will add to this, just to complete this thread, I hope, is in addition to those issues we just talked about around, paying for help at home or nursing facility-based care and long-term care insurance, there are other services, of course, that are supplemental. They do not offer folks that can come and live at home or be there for long periods of time to care for folks, but for example, elder services is a great resource for people that are of what age?
I believe it can be 60 or older.
60 or older. And you want to say a little bit about elder services and what they provide?
Sure, Elder Services in Worcester, we're covered the Shrewsbury area, and you can call them. It's a free phone call. They would come out to your house and do an evaluation for free, and to talk to you and other family members and help you kind of figure out what it is that you're looking for and what kind of services they can offer, PCA services, homemaking services, things like that. And usually it's on a sliding scale. It's based on your income, how much you would have to pay. So they're a very good resource. And also I'm sure that the Shrewsbury Senior Center is a very good resource, or whatever town you live in, for finding out what kinds of programs are available and that you might be eligible for. So.
In terms of palliative care in the community, so we started talking about, and before the folks came in, we were describing how our palliative care team sees people in the hospital when they're often in crisis, and help them with different symptoms and help with goals of care discussions and providing support for people through that crisis. And then we have a clinic where we see people on an ongoing basis alongside their other doctors. And we're trying to build palliative care that can go to people in the community, to their homes, to assisted living facilities, to nursing homes. We just hired a part-time physician to be our first community team member. He's going to be going to some nursing homes, which is great. It's a start. So, but in the meanwhile, we partner with other agencies that we know of to provide some palliative care. So there is, for example, at the VNA Care Network, they're a not-for-profit organization in central Massachusetts, and they have, for example, a pilot with Blue Cross Blue Shield to provide home-based palliative care for people who have Blue Cross. There is also another agency, Notre Dame Healthcare in Worcester. They also provide home-based palliative care through a Medicare grant-funded project. So the government and private insurers are trying to experiment around how do we fund and pay for palliative care outside the hospital, outside the clinic, where people really live. And so that's why we see some of this experimentation going on in terms of how to pay for that. So that's actually, we're actually quite fortunate to have that here in central Massachusetts, that we have those pilot programs. And we work and refer to them all the time as extensions of our program, and then we collaborate. So it's a way of starting to build that infrastructure in the community and hopefully then build from there. Because that's really kind of the vision of how we build that everywhere, palliative care everywhere. So
I think as you see the palliative care teams, we are aware of a lot of resources that are in the community or outside of the hospital, including various other programs that we haven't mentioned, so that we can help you connect the dots. Right? We can try to have you access the most amount of resources that are available. Do you have any questions?
I have a couple of thoughts, but I'm not sure where to begin. One is there someone on your team who might be considered a death doula? In other words, like a midwife, but assisting the dying person in the process of dying, not fighting it, but accepting it.
yeah. So everybody,
Have you heard that expression?
Yep.
yes.
Yes.
I don't know if
Yes.
anyone here knows what a doula
Yes.
is,
Yeah.
but a doula is a person who, well, it's probably more commonly known in settings of childbirth.
Yeah, and of course.
So a person that accompanies a woman and family who are expecting a baby, woman in labor, to help provide support during that really important life moment when this baby's coming into the world. And so that term's also been used thinking about the dying process and how that's a life transition and how to help someone at the very end of life. So I wouldn't say we don't have a death doula on our team per se. We, though, are very much about helping people. Palliative Care's mission is to help people live well with a serious illness for whatever time they have, and also help them to plan for when end of life comes, and to make sure that we help take good care of them through the dying process. That often means also partnering with hospice. And we haven't talked about hospice yet either, and how that's the same or different than palliative care. So, are folks familiar with hospice? I see some people nodding their heads. Yep. So hospice really, I would say hospice and palliative care are sort of cousins. So we both have a similar mission around improving quality of life, taking care of the whole human being, not just the physical, but emotional, social, psychological, existential, spiritual, and the whole family. And helping people have as much quality time for whatever remains. And hospice care really, as you know, is palliative care, specialized palliative care for the very end of life, meaning people who are usually in their final months of life. And hospice is an amazing system of care as well as a philosophy of care, because hospice actually, getting back to practical issues, hospice has a very robust insurance benefit which provides a lot of services. So Medicare and other insurances cover an entire team, much like ours, and those folks are on call for 24/7, where they live. They don't move into people's homes, but they can come and be on call in the middle of the night or on the weekend and come to see the person to help troubleshoot with whatever's happening. And that, the goal of hospice is to use that specialized team for that person and family to help make sure that the person is physically comfortable, not in pain or having any other distressing symptoms, to provide emotional support, to help walk with them and their family through the changes that the dying process brings through dying and then bereavement. Hospice also provides bereavement support for loved ones for 13 months after someone dies. Hospice, the insurance benefit also provides, pays for any medications or equipment related to the illness, so hospital beds, oxygen, dressing supplies, a whole host of things. So it's kind of the Cadillac of insurance benefits in this country in that it covers a lot. People don't move in, but it provides a really robust sort of safety net to try to help keep people where they're happiest, where they want to be at the end of life. So palliative care doesn't have that robust insurance benefit, so that's why we are still trying to figure out as a society and as a healthcare system how to build it in the community and pay for that. So we'll get there. So I don't know if that answers your question. It's really more, I think the concept of a death doula, is a lovely concept, and I think we are absolutely and do a lot of end-of-life care because we see our patients all the way throughout their illness and end of life, and we've been doing this, we do this all the time, and we partner all the time with hospice as well, who can really provide a lot of intensive support.
You mentioned that one should have a conversation with their financial consultant. What type of, how do you start with that? Do you just say, if you need a palliative care, how much money should I set aside for, or how to fund that type of services?
I think that's a really good question. And I think what people have to think about is how they want to live their lives, especially once they retire. Are you retired?
Yeah, many years ago.
Many years ago, okay. Are you enjoying your retirement?
Yeah, because I do a lot of volunteer work with the Shrewsbury Senior Center myself.
Wonderful.
And some of the things I knew about is because I used to, and I still counsel the people with their Medicare insurance or supplement insurance and those kind of things.
So I imagine that there's somebody there who, sometimes there are counselors who will come to the senior center and talk about how to save or how to manage what you're going to need money-wise for if you get to the point in your life where you need to have care in your home, or you need to go to a nursing home.
I've been involved almost more than 12, 13 years and I've not seen that kind of thing coming up in the... And I think there are certain guidelines, who can come and what kind of sales pitch or whatever they can give, because you don't want to involve thinking you're supporting that program or something, and then there are a lot of
I understand what
bad
you're
actors
saying.
in there too, I guess,
Yes.
so it's very difficult for the senior center to do that. But I mean, what I can suggest is, I know we are not done yet, but something like this discussion should be happening in the senior center itself. Because that's where a lot of people comes in. Of course, until you provide some food or anything, there's a lot of time. Nobody shows up, or maybe just like this, there is only half a dozen people shows up. That's a reality I just found out with many of the speech or talks or discussion, which is kind of sad in that respect.
Well, I think it's wonderful that you do all that volunteering, and I'm sure that they appreciate all the hard work that you put into that.
Thank you.
That's really a gift to your community. So one of the other things that I could suggest is that there are insurance companies or financial planners who are listed with the Better Business Bureau who have a pretty good rating, and they can be people who you could get some advice from. Usually it's free. They may have something they want to sell you, a policy or something like that, but you don't have to, usually you don't have to pay for that conversation. For instance, at UMass,
Yeah.
they have an arrangement with Fidelity.
Yeah.
And so we can go to seminars and things and we can talk about, retiring and, end of life, not necessarily end of life, but how am I going to save for that time when I may need more help in my home? So we have that available to us too.
So do you have excuse me, do you have somebody, you said, you mentioned Fidelity, so the UMass works with the Fidelity?
Yes, they do. They have a contract, I believe, with Fidelity so that employees can talk to them about what they may need in their retirement.
Because I'm a Fidelity customer, and
Well, then-
something like that I have not come across.
Who's your broker? You give your broker a call. Who's your person at Fidelity? Do you have a person?
Yeah.
Give your person a call.
And just ask for, I need to get some information in
Yes.
reference to palliative care.
Well,
or-
tell them, that you are looking for maybe some more financial planning for if you were to need some more services in your home towards the end of your life.
Okay.
And, what would that look like for you?
Because I meet with my person every probably 3 times a year, but this discussion has never come up.
Well,
And that's why when you
so-
mention
Right.
that,
Yeah.
I want to get a roadblock in to say, hey,
Right.
how do you start that?
Good for
Right,
you.
right.
And you would be the one probably who would bring up that conversation, as opposed to them saying, hey, I'm not sure that that's something they'd be comfortable bringing up with you. So it's perfectly appropriate for you to bring that up with them. It's a wonderful idea.
But just like this gentleman said about no fear, once certain people I deal with, or sometime in the conversation, I say, I've achieved most of the thing in my life. Something happens, I'm not fearful of the death. So,
You're not,
pardon?
I didn't hear what you said.
What I said is, before you came, there was something has to do with the fear in the life or whatever. And what I'm saying is, I've prepared mentally myself, saying something really happens, I have no regrets. Many times people, when they hear the word death, you sat back and said, you should not think about that. And I said, I'm not thinking about that, I'm just saying that something happens, I'm prepared.
You're
Yeah.
prepared.
Thank you for saying all of that, and I think that's actually a really good segue, because one of the things we also were going to bring to you all to see if you wanted to talk about was advanced care planning. We've been talking about a lot of the practical and financial aspects of advanced care planning as people age or have health problems, but also this idea of helping make sure that we stay in control of our own story as it unfolds through every chapter, including end of life, as well as helping our loved ones understand our wishes and our priorities and our values, and if we have them, specific preferences around our medical care, and preparing them so that they feel equipped to make decisions for us if we can't. That's key, because we see that all the time. And as a person, I've lived that, of course, in my own family as well. And I've seen when conversations have happened and the outcome versus when they haven't, and some of the distress that can come from that. And so that was another piece we wanted to bring up with you all, if that's okay. So we wanted to talk a bit about reinforcing the value of having a healthcare agent, that all of us should have one, as well as potentially writing down some of our values, beliefs, priorities, things that our doctors and the healthcare system should know about us to help inform who we are as a person if we were sick and then we're facing different medical decisions. So, I'm going to turn that over to Nancy to talk about healthcare agent.
How many people in here have a healthcare proxy? Wow. That's awesome. That's wonderful.
One person, we will target
Yes.
I'll change that.
We need to talk to you.
You think she's young enough?
Yes.
Anything can happen anytime.
Yeah, that's true.
Unfortunate.
Right.
So that's what we said, right?
Right.
18 years or older, we never know.
This is the reality. I also go through, even some of the seniors, they don't have a healthcare proxy or will or durable power of attorney. And I guess sometimes I tell it's, all those things are not really age related. Because
Oh, no,
in today's fast world, you never know.
That's right. And some people don't want to talk about it because they think they're going to make something happen. If I make out a healthcare proxy, then I'm going to need that healthcare proxy. And we say, well, if you have a shovel, does that mean it's going to make it snow? Not
Yes,
necessarily, but you have one because you need a shovel. So healthcare proxy is, they're different from state to state, but in Massachusetts, it's an opportunity to have somebody speak for you, as you all know, if you can't speak for yourself. And it can be temporary. I think that's another barrier too, is people think, oh, I'm signing away my rights. And that's not really what it's for. It's to be protected, because that person can speak for you for your medical care, so that you're getting the medical care that you want. You're not getting something that we assume you want. We know what you want. And that keeps you in control of your own medical care.
And that's only if you can't. You always are, you have control of making all of your own decisions. Everybody has that right. So that agent only gets activated if you can't. If accident happens, you're confused from some infection, it's momentarily, those are the only times that person is active. So it's not that you're giving away your choices and rights to somebody else. I think that's the biggest fear a lot of people have. That if I do that, then I won't be able to be in charge of my own healthcare, but that's not true. It is only if you need it. And everybody, especially in this state, 18 or older, needs to have a healthcare proxy, or just in case something happens.
Can you say who decides when the healthcare agent becomes activated?
And you,
That was a related question. You have a healthcare proxy, but when you go for your annual physical or something, your doctor is not asking for it. So it's lying in your home or with your dear one whom you have nominated. And if something were to happen to you, how does the treating doctor know that X, Y, or Z needs to be activated to talk and act on your behalf? So you have that, but most times it's just lying like a dud agreement, which is never put into practice.
Right.
So if you could help us walk through that process.
again, very important
Yes,
question.
yes.
So, again, I'm not trying to jump to one side, but it's a good question too. And the best thing what I learned from that is, one, you should give a copy to whoever your agent is. Second, every time you go to doctor or PCP or something, you should give them the copy also. If you're going to be admitted to the hospital for any kind of elective surgery or anything, you should take that and give it to them. So that way it is already on the file at some of the places you do business with for your health care. How they're gonna activate that, that's a whole new story. Like say if UMass has my healthcare agent, I don't know when time comes, are they gonna look for it, or is there a quick
Yes.
thing in the EMR system
Yes.
that it flags it, you know?
We're going to hunt for
So
that.
that's a very sound advice.
Yes.
So
So-
yes, if you do a healthcare proxy, and which is the name of your healthcare agent, the first one is a primary agent, second one is an alternate. I think a lot of times we get into difficulties is people say, oh, we did it with a lawyer and it's in a locker of a lawyer somewhere, nobody can find that person, nobody remembers the name of the lawyer, nobody knows how to access it. So if you have one, make sure that you are giving it to your either healthcare agent. They know they are your healthcare agent, first and foremost, right? So who is the right person for healthcare agent? Who actually knows you well? Who knows your wishes? Who knows how to take care of you if you can't take care of yourself?
So what happens if you're injured, when you're traveling or you're, not close to home? I mean, how is a healthcare agent brought up in that circumstance?
So it's, I think any place you would go to, any hospital, if you can't make decisions, they will try to obviously just like locate family, like the hospitals would do, and then they do start looking at who is your person who would make decisions for you. And in a lot of states are less stringent in, they would say next of kin is your decision maker. Massachusetts state is different. It has to be a healthcare proxy who makes decisions for you. So the right person, I think we going a little backwards. You appoint a person as your healthcare agent who knows you well. Who you think will make decisions where you would make decisions. So role of healthcare agent is not to make decisions way they want it, but way you want it. So that is the very important person to make decisions.
I'm going to ask you ladies, I'm going to turn the question around. If someone calls an EMT, that person has to do CPR, even if they think you might be brain dead? In other words, if it has taken more than 3 minutes to try to restart your heart, then you are very likely in the process of becoming brain dead. And my understanding is that they must, if you've called the EMT, they must do CPR, even if you do not want to live brain dead.
So that's bringing up a related but
Another
different
form.
topic, but a
Yes.
very important one. So, so you're right, if 911 is called, paramedics do what they do, and that's to try to save people's lives and to do CPR. And however, if someone is living with a health condition where CPR becomes risky, or it may not be very successful, or if it did bring someone back, that wouldn't be the quality of life they would want, that any of us as people have control and rights to be able to say what we want for our medical care and our bodies. So people can decline CPR. But to your point, if we were sick enough to be in cardiac arrest and you can't speak, you can't tell that to the paramedics. So as a result, there is a decision-making process for people to decline CPR ahead of time if they had a cardiac arrest. So let's say someone has advanced cancer or some other serious illness, and we know that it's a real risk-benefit sort of discussion about, is CPR going to help this person if, God forbid, they had a cardiac arrest due to their underlying problem, which may not be fixable, right? So that person might elect not to pursue CPR. So how do we make sure if 911 is called that the paramedics don't do something that the person wouldn't want? So there is a process for doing that around the country and in Massachusetts using physician orders that are portable outside the hospital. And this form is called the MOLST form. It's a bright pink form. I don't know if anybody has seen that. We should have brought one, but this was really, it's sort of related to advanced care planning, but it's really very specific around CPR. So can I ask, can one of you pull it up maybe on the screen? We can show you a picture of it. But this form is something that you can talk about with your doctor. So let's say for whatever reason someone wants to avoid CPR at the end of life for a very serious, incurable condition, and they made that decision. How do we make sure that that's protected? You can fill out this form with your doctor, and it's a physician order. So the person themselves signs it, and the doctor signs it, and then that gets copied and scanned into the electronic record with a physician order in the health system, but then you take it home, and the person puts it on their refrigerator or has copies of it. They tell their loved ones, because this shouldn't just be a piece of paper, so that everybody's aware of their wishes.
So is that the same as a DNR?
Yes.
So yes,
Okay.
that's a do not necessitate order, exactly.
And they're trained to look
So the
for it too.
paramedics will look for that if 911 is called.
Yeah, but
Hang on for just 1 second. Did that answer your
You're gonna need
question?
to log in. Okay.
Sort of. But I think my question is more general.
Okay.
If one knows that after a certain amount of time, that a person would, by definition, become brain dead because they haven't gotten enough oxygen. I mean, the paramedic is going to take 10 minutes, and the person starts becoming brain dead after 3 minutes, that there's almost an illogic to trying to start someone's heart if it is clear that they are already brain dead. And that's any of us, not dependent on other circumstances of life, but just by definition, I mean, why would one want to start a heart someone brain dead?
I'm gonna give you that.
Good.
The problem is that outside the hospital, you just can't know the answer to that. So just the way the
Doesn't it
systems are
already-
set up.
Isn't it after 3 minutes?
Not
Not
necessarily, it
necessarily.
really depends upon
And it
many
really-
different factors.
Yeah,
So how long after a person is
Again, it depends on so many other factors on how sick they were. Like in cold situations, sometimes they will find people outside in winter who that feels like their heart is not beating, but that's also because they're so cold that it has actually preserved the body, and when you rewarm and do everything, they actually do fine. So it's very much different based on different circumstances. So that's why EMS, that is their job, they're obligated to do everything, and they would attempt it. And of course, if it's not successful, that would be called off after a short while, but so many different situations are under different situations.
I think you're hitting my point, but not exactly. I mean, I think there are stories where people are given breathing tubes who are brain dead.
Have you ever had that conversation with your doctor?
Well, it happened to my son's father. And,
Because I'm just wondering if that isn't a conversation that would be good for you to have with your doctor to talk about, kind of what you think your wishes might be
well,
in that situation.
I have signed something.
This is the most form I think you guys were
This is what the
talking
form
about.
looks like. In real life, it's bright pink so that the paramedics can actually, see it, and they're trained to look for it. So this ties back into what we were talking about around healthcare proxy forms. So proxy is the form, and healthcare agent is the person, just for clarification. And I agree that we should bring our forms to our physicians and that they should be asking us about it. It should be part of, say, the annual medical wellness visit. In fact, that's encouraged now. And that we scan the healthcare proxy form, and if someone has a MOLS form, into our electronic medical records. And we, as palliative care folks and in healthcare in general, we're trying to make sure that they can be easily retrieved and seen and even shared across health systems. There's an effort here in Massachusetts to create an information highway where we can all see, no matter where we are in the state, these different important documents that are meant to, portray our voice if we were too sick to speak for ourselves. So, we try to do a lot of work on systems to make sure that our electronic medical records and the way we do handoffs and talk to each other within healthcare help support if we've made decisions or had conversations ourselves at home, at the kitchen table, or we've made different decisions, that how do we steward those, in our healthcare system. So.
I have a couple of questions, they may be unrelated. What is the life of a healthcare proxy form? I mean, at what frequency do I need to revalidate that?
So actually, there is no life. Typically, if you fill it, it is valid. There are very few situations where that could be called into question. So a lot of times it happens with if your spouse was your healthcare proxy, but then you ended up getting divorced, then that does come into question if that is valid. So it's always good to do that if there was any major life changes to make sure that you have a recent one. Otherwise, it doesn't necessarily have a life as long as it was done valid, which means it has the witness signatures, it has the date, and all of that were written well. It stays valid for all of your life.
You have to be 18 years old or older, but it doesn't expire unless you change it. And then you just do another one. You don't need a lawyer, you can just need 2 witnesses to witness your signature, but you can just do another one.
Okay.
And
There are
those
no
witnesses-
regulations that keep changing with time,
No.
that you need to keep doing.
And
Believe
I
it or
think it's
not,
just
no.
that the biggest mistake some of us make is the witnesses are the people who are the healthcare agents. So that's not allowed.
And it says that on the form too.
Yeah.
Tells you how to do
So
it.
you
What
have,
was-
but
I did not hear that.
the healthcare agents, the names you would have written cannot be the witnesses. So for it to be a legal form, it's your name, your healthcare agent first and second, and 2 different people than that. So
Oh,
the
for
first
the-
3 names cannot be the witness.
For the validation.
Right,
Yes.
and then it has to be dated.
And I believe there is an alternate healthcare agent too, like
Yes.
So
usually
healthcare
there is a
agents,
primary, and then
then
if primary is not reachable, the
Yes.
secondary
Yeah.
comes in.
That's right,
Yep.
exactly, right.
And I think someone had brought up the point that at the end of the day, it's just a piece of paper. So yes, we want to, it's an important piece of paper, and we want to have it in the right places and share it with our healthcare team and have it in the electronic medical record. But at the end of the day, we want to make sure our families, our loved ones, know about it and that we've had discussions with them. Because we see all the time that even if someone has completed a healthcare proxy form, if they don't necessarily talk about their goals and wishes and priorities with their loved ones, there still can be a lot of conflict that can happen in crisis. And so, you know, and healthcare agents can feel very stressed, like they have the weight of the world on their shoulders. And so proactively having family-based discussions where people are on the same page as much as possible, even if those other folks are not the agent, it helps the agent, it helps the person who's sick, it helps the family hopefully, you know, be able to come together, show love, you know, try to rise to their best selves and overcome whatever the issues are to try to help that person who's sick and hopefully come out the other side together still as a family. That should really be the goal of this, not just the paper.
So I want to do this. This is a kind of a test. I am a UMass patient for certain discipline, I guess. I have access to my own portal. So I'm going to maybe give the copy to next time I go to whoever is the doctor is concerned.
Sure.
And I'm going to make a test saying, can I access that document, or what's going to happen is within your organization at UMass,
Yeah,
when somebody comes to the new doctor or specialist, are they going to look for something like that first, that by the way, does this person has that? Because that's a key thing, you know, any new doctor you go to, that they are aware of that.
yeah.
So I don't know if it's going to flash on their system when you check in, you know, that this person has,
It would be in the system, it'll be scanned in the system. So if you hand them the copy, it should get scanned in the system, so that if you ask for it, do you see it, everybody should be able to
So when I
access
log in on my portal, I should able to see that it's stored someplace?
it. If you have access to that particular
Yeah, I have
document
it.
base, then it should be.
Well, I have
I'm
a
not
system.
sure my chart has access to what different.
But, so that's something again, you need to take that part of this further concern from here. That is it available or not, or how does your
Through the
Epic
portal.
system, how does Epic
Yeah.
system is really using that information, you know? Because if it's not available, or as soon as you are in the emergency room, if they're not looking at first thing,
No, if you are in
Yeah,
the
it's there.
system and we need it, everybody knows where to look. I just don't know whether you are able, like my chart
or me
has
as a
access to
patient,
it.
okay.
Yeah, we worked very
We all have
closely,
the access to it.
yeah, with our electronic medical record team to create a very special place right up front. In fact, under the person's name and
It
medical
says
record
there.
number and date of birth, it's right there where you can hover and find it quickly. So we've worked really hard to advocate for that, so.
Because I use highly that system, and many a time I responded with certain things that I think it's a roadblock, but I get a standard answers, you know,
Yeah.
through the mail, I guess, or technical community. And something I want to work with your Epic system guru to see how some of the thing can be resolved, you know.
Yeah.
You had a question.
Yeah, it was a follow-through of what my friend was asking. You have a near or a dear one who has a chronic ailment, and then, over the weekend or late at night has a natural death. So what would be my role? Do I call 911 because I'm not going to get the primary care or the treating doctor, and then later, what am I expected to do? Because if I call 911, they're probably going to come and resuscitate or whatever they think. So what should, if you could guide me, how do I handle that?
Well, if your loved one has a
Or just old
MOLS
age?
form, just
I mean,
old
no-
age has a MOLS form, they'll know that not to do CPR, resuscitate them, but they also check for vital signs when they get there. They're gonna check for a pulse and a heartbeat, so if they don't find those things, they're not gonna do CPR if there's nothing to do CPR on. And then they might have you call if this person has made arrangements with the funeral home, you can call the funeral home right away. But I think that's a big part of it is if there's no pulse, they know how to check for those things, they're not gonna do CPR.
And if it looks like it's been
Quite a long
quite
time.
a
Yeah.
long time. And they would also ask the family that's there too, most likely about, what's going on, what should we do, and, try to make a decision in the moment as well.
So the next steps are then call a funeral home and then wait for the next working date to get in touch with the treating doctor or something as to say this is what happened?
Not necessarily. If the person has died, you can let the treating doctor know. I'm sure that they would want to know that their patient had died. But what you would need to do then is to call whoever is going to do the services or whatever that person had wanted to do.
So if in that instance, if the person were not under hospice care, at what point is a situation like that considered an unintended death versus, if you were in hospice care, you'd be dealing with a hospice nurse who would kind of guide you through the next steps.
Right. Well, I think it has to do with if this person is alone, you might call the EMTs, they might call the police, and I don't know if then you would have to have some kind of a medical examiner, that kind of a thing. Depending on if they were by themselves or not.
Right.
So yeah, and they can guide you, they can let you know, you can make that phone call to either EMTs or the police, and they can guide you as to what to do next.
And then who would issue the death certificate if you're not getting in touch with the treating doctor or somebody? Then who is responsible for that?
That's a really good question. I'm not sure.
Primary care physician most likely
Probably.
be asked to fill out the death certificate, probably.
Probably have to call 911 or you're gonna get accused of murder.
I think medical examiner.
If there's no hospice involved, I would.
Yeah.
Right, well, and
Yeah,
also.
then you have to call, you have to call 911 or probably the best thing to do.
I would like to share who I am for a second.
Please do.
Okay, so my name is Devora, I live in Connecticut. I have a daughter and 5 grandchildren in Shrewsbury, and we started looking for a place to live near our daughter, and without success, so our son-in-law offered us his garden to build a place. So we are about a month away from moving in. We are trying to build an accessible, a situation where we can age in place in our daughter, in our daughter's garden, so like our garden apartment. We're trying to figure out what is an accessible shower, see if we need a wheelchair, all the situations that could arise. We're going to be looking, myself and my husband are going to be looking for a doctor. Also, if any of you would, but I did want to say one thing about Connecticut. When I went to get this DNR after my son-in-law's father was forcibly given CPR and kept alive for a week, being brain dead with a breathing tube. He told me to go get a DNR. So I was in Connecticut, and what they gave me was this orange band that I had to wear 24/7. And walking into the grocery store, and, with my grandchildren to their programs, wearing this orange bracelet, it felt really weird. It totally weirded me out. So I took it off. But in Connecticut, that's what you have to do if you don't want to be resuscitated. So it's like they force you to stay alive. So I think this healthcare agent, the job of that person is to help you die, which is why I asked about death doula in the first place, because the medical establishment tries to keep you alive no matter what.
Yeah. So the healthcare agent is really meant to be, as we said, our voice for when we can't speak for ourselves.
But to let us go.
Well,
if we
yeah,
didn't need
that's
to,
what
if we
you
didn't
want.
need
Either.
to be,
It
now,
depends.
even if it's not,
Yeah.
the medical profession is going to try to keep us alive no matter what. And sometimes that could be for their own financial.
Mm.
I don't know.
Yeah.
I don't know.
Yeah,
It's,
there's a lot of forces that sort of, and culture within medicine around saving lives and curing disease, and thank goodness for that. But
do
we
you
have a 100% mortality rate, unfortunately,
Yeah,
as
we know
people.
that, right.
And so, this is partly why palliative care exists and hospice care for people who are dying. But to help make sure, what we're all about is making sure that people's medical care fits with their goals and their priorities and their values and who they are. And for some people, the medical fight, even in the face of an incurable illness, is very important and very consistent with their values and who they are. And they want that, and that's what we tease out in terms of, there might be a younger person who's a parent who is looking for as much time as possible, even if there's discomfort and a lot that they have to go through to get more time. Whereas someone who maybe is older and has lived a full life and feels ready and more at peace with the end of life, that trade-off may be very different. And so it's all about us trying to unpack who is that person and what is the right thing to do. So it's really about that kind of advocacy.
Yeah, but what I'm trying to personally, in my life now, moving behind my daughter.
Yeah.
So I'm trying to create myself the kind of life where I can age in place safely and peacefully.
Yeah.
And, still be reciprocal, be able to be helpful. I'm grandma clock in that house. So I wake the
Nice.
kids-
That's wonderful.
I wake the high school kids up at 5:30.
And I think I just want to point out one more thing, is the forms we're talking about, where do we keep these forms? We definitely keep it in your question, like if there was accident, how does anybody know? I think in this age of electronics, we do recommend people to take a picture of the form. That's the last thing you can do. It'll stay in your camera on your phone. And that way, if you are there and somehow your family member has your phone or you have your phone, you can at least show them this is my healthcare business. So you don't even have to have a phone with you. You can have a picture and that can be printed out.
My mother recently made her own sticker and taped it to her car windshield. Because
Wow.
she's so concerned about it being accessible.
Yeah, so
It's
it's just that, yes, filling a form is one thing, but actually making sure everybody who needs it has it is the very important thing that I think most of us
Yes.
miss that.
Speaking of this topic, we just want to make sure that we share some local resources for all of you as well. So this is a really good website. It's called Honoring Choices Massachusetts. And it's a not-for-profit advocacy group. It was actually founded by an elder attorney who found that her clients that she was counseling on financial issues hadn't really thought about healthcare and advanced care planning. And so she felt that it became her mission in life to help equip people at every stage of life and to empower them. So she created this Honoring Choices Massachusetts. So she does many things, but one of the things this website does is you can get a healthcare proxy form to download. You can do what's called a personal directive, also known as a living will, which is not a legal document, but is more of a form that walks us through thinking deeply about what matters most to us, what is quality of life for us, what are my values, what if I were at end of life, where would I want to be, what kind of care would I want, what are the cultural or religious traditions that are important to me, what does my family need to know, what does my healthcare team need to know, all of those things. And so those documents she has here on this website in a variety of different languages, and because our central Massachusetts community is very diverse. She also has a number of videos here where it has testimonials of people speaking in their native languages about why it matters to have a healthcare agent and things like that. So I wanted you to be aware of this website for yourselves, as well as if you're involved, say, at the senior center. It's a great thing to be able to share. And then one other really great resource. So for some people, doing a living will or a personal directive might feel a little too form-like or check boxes or what have you. And so another way of doing the same thing is writing a letter. So there's a group at Stanford that developed this thing called the Letter Project. And it's essentially writing a letter to loved ones or to your doctor about what matters most and what your values and priorities are. And that's a lovely concept as well. And they have some templates to help people get started, and they have it in multiple different languages as well. So just want to make you aware of those two resources, just as an FYI. So thanks for letting me squeeze that in before we run out of time.
These two resources are available, but let's say a person like me who has a portal on a EMR Epic system. Does it before even you log in or sign in, does this link or something is available for these two websites?
So let's say, so the patient portal at UMass in Epic doesn't link directly to these sites. But let's say you decided you liked the letter, or you liked the advanced directive from the Honoring Choices website. You could download it, either fill it out on paper and pencil, or fill it out electronically. And then you can either email it or give it to your doctor. And we have a process of scanning documents in to our electronic medical record, and that will pop up in your chart with your name, and like I said, in the same area where the healthcare proxy form is, and if someone had a MOLST form, all of that, we created a space within the chart that is highlighted where all of those things are kept in a box together, so that can be easily retrieved.
I don't think I explained you properly there.
Okay.
These two websites which are available, I don't want to remember this or this two website.
Yeah.
So when
But
I
no,
log
there
into
is
the
no
UMass
direct
portal,
Yeah.
you know, one of there's several informations available on that. So if the availability of these two websites somehow is there, that
Yeah.
helpful resources, and in
Yeah.
helpful resources, this
Yes.
one, so what I can do when I'm in the home page,
Right.
I can just click on that.
Yes, so we're actually working on, so we've been working on just on sort of the healthcare team side of getting our act together to get all of these things in one place so we can honor them. You're right that the next phase of work, we are working on patient education materials, if you will, or resources, so that you could go to a place and be able to click on these places and be able to access it, you know, even upload things through the portal yourself, or different documents. So yes, I can't agree more, and that is part of our plan.
So again, this is something like this, when I use the system, I always have this kind of things, and I say, send the information, this is the idea or something like that to link. It goes into never land. I never get any
Yeah,
kind
that
of,
should never happen.
I
We don't
never
want
get
that to
a
happen in
good
healthcare.
response from the
Sure,
system on the other side saying,
yeah,
yeah, we can do it today or this month, but that's something we can take care of it in next 3 months or something like that.
yeah.
Because otherwise, all these good ideas or whatever,
Right,
it just goes
we have to act
down.
on them and see them through, not
So-
just do them at home and do all of that. They need to
Yes,
be
I don't know,
actionable.
I'm
Right.
here to help you folks also in the
Keeping it
retrospect.
real, yes.
But
Thank
how do
you.
I do that? That's my concern.
Yeah, all right, we hear you, 1000%.
Thank you so much for your time and all that. I don't want to hold you up any longer.
No, I think we have until 8:30, was it?
We can do it.
Yeah, so we have about 5 more minutes.
Okay, so if I understood in a sense what you're saying, most of us, when you retire, will probably be on Medicare. So Medicare would take care of some of the hospice expenses, but not the palliative care. Is that a correct understanding?
So, can I answer that?
Yes.
So, just like any other physician or nurse practitioner specialty, our field also, insurance covers our services. So just as if someone went to go see their cardiac doctor or a lung doctor, that insurance covers the services of the physician and the nurse practitioner. So it's not as though palliative care isn't covered by insurance, that is. And that's very familiar no matter whatever specialty you see. In terms of the sort of bundled services of hospice care, which includes all the things we talked about around not just the clinical team members, but social work, music therapy, chaplain, home health aides, as well as the 24/7 on-call, the equipment coverage, the medication coverage. All of that is bundled under the Medicare hospice benefit, and other insurances cover, follow what Medicare does. So hospice is widely covered throughout insurance. So that insurance system is unique to hospice. It's not the same for palliative care. Even though we're cousins, we don't get that same benefit. So, but we're just like any other medical specialty in terms of, you can still go to see a palliative care physician or nurse practitioner, say in clinic, or when someone's in the hospital, just like any other specialty, it's billed under insurance. But all those other services, we are still figuring out how to pay for those, and that's why it's taking longer.
So my understanding is Medicare covers hospice care.
Yes, and
But-
palliative care.
And palliative,
Sure.
okay. I
But
thought,
not the same wraparound service model in the community that hospice does.
so palliative care, Medicare covers it, but very limited, is that what you're
It
trying to
covers
say?
it covers the clinicians involved, so like a doctor, a nurse practitioner. So just like if you go to your primary care doctor or to a specialist, if you go to their clinic or you see them in the hospital or have a procedure done, all of those things are billed under insurance. So same story with palliative care. It's the hospice is a unique construct that was developed in the 1980s by an act of Congress for the Medicare hospice benefit that created not only an insurance benefit, but really a system of care that was very inclusive, that helped take care of the whole person, all these different team members, the practical supports at home, the medication, the equipment, the on-call. It's meant to help people who are at end of life, who are focused on not being in the hospital, but being at home, and how can we as a society use our tax dollars to support those folks to help them be at home. That was the spirit of the Medicare hospice benefit in the early 80s, and that's continued. And now palliative care has grown out of the hospice movement, and we are not contingent on whether someone is at very end of life, because people who are getting palliative care could also be potentially still getting life-prolonging or even curative treatments. Like I have patients who say have leukemia or lymphoma who are getting chemo and maybe a stem cell transplant. And we're helping them control their symptoms, provide emotional support, accompany them on this road to see how they do. And whereas with hospice, people have to forego life-prolonging treatment. So palliative care kind of grew out of hospice philosophically and to meet the need, because we don't want to wait to focus on quality of life until just the very end of life. We need to move that way earlier in the trajectory of illness. But the financial model didn't follow palliative care. So we are now trying to figure out how to build that in a more robust way like the hospice world has. And that's why, getting back to the beginning of this discussion, I mentioned how payers like Blue Cross Blue Shield or Aetna or in other states have been paying for palliative care as a similar model to hospice, meaning they have them on call, they have the interdisciplinary team, they're paying for medications, and they're kind of testing to see, does this model work? Do we want to invest in that in the same way that the traditional hospice insurance works? Does that make sense?
Yeah, so it sounds like there's a lot of ancillary coverage available through the hospice right now, which Medicare covers it.
Yes.
But those ancillary services are not really covered under the palliative care. That's what,
Yeah.
Outside the hospital, yes.
okay.
So in our hospital, so Nancy, we have a music therapist, we have a pharmacist, we have team members that don't quote bill for their services, but they're part of our team, and it's part of the way the hospital underwrites our program. And then we also have a clinic as well. So you have billing providers that can help, offset or contribute to the plan for how to build and grow that program. But doing that out in the community, that's a little more challenging. How do you pay for all of that? So that's sort of what keeps me up at night or thinking out loud as chief about how do I strategize to figure out how to have it everywhere, because that's really the goal. And lots of people all around the country are working on that right now, and so are we. And we're doing it one dot at a time that we connect.
I promise this will be my final
No,
question.
no, this is great, it's great. This is why we're
So if I had a near or a dear one or a friend whom I want to refer for palliative care and I would call, what's the approximate waiting time to get an appointment?
for clinic.
Yes.
Thankfully, it used to be at least 2 or 3 weeks, but now it's not. Sometimes we can see people, especially if it's urgent, the same week or the same day even. We have a wonderful nurse practitioner named Pam Lane, and she and I are the 2 providers in our clinic. And we've gone from a day and a half a week to 4 days a week now, which is big for us. And we also have our pharmacist, Delilah, who's with us in clinic. And we are in the ACC building at University Campus, if you're familiar with UMass. And we are on the same floor as the Cancer Center, but we see folks who have all different diagnoses. So we, like any clinic, we need to triage how acute the situation is, but our access is much, much better. So I did bring my card with our office number and my email for folks that if you have, feel free to be in touch for anything, but if you in particular know somebody that would want an appointment, you can call that number and speak with our assistant, Debbie, who can help make an appointment.
Thank you very much.
Yeah.
Thank you.
Thank you, everybody.
Yeah.
So this is probably a really silly question.
No.
I
No
don't think
silly
there's
questions.
a clear answer to it. But kind of piggybacking on your point about trying to move the trajectory of palliative care earlier in life, I come across a lot of people who aren't quite as open-minded about discussing end-of-life issues as the people in this room. And, thinking about someone who's not chronically ill, I guess, do you have any advice for how you start that conversation, for someone who tends to kind of keep their guard up a little bit and may not necessarily see the need for it, but whom it would probably be beneficial to start the discussion early on?
Yeah. So, and you're talking about someone who is living with a serious illness, or someone who maybe not is not?
Yeah. I guess the specific person I had in mind is not, but I think other people, are dealing with chronic illnesses that may not have any imminent thing expected, but are still a little bit low to think about that.
Well, I think that we as a team, it's important to meet people where they're at. So, at the end of the day, people are where they are in terms of how much they're ready to think about planning ahead. I think tonight we talked about how, at the very least, encouraging people to have a healthcare agent is big, because then you're still planning that if something unforeseen happens, you have thought about the what-ifs of who would speak for you if you couldn't, and also having a conversation with them about what's important to you. So that should be at least the lowest rung, if you will, to sort of set the stage for future conversations. But we see this all the time in palliative care, where people are diagnosed with a serious illness and really, as you can imagine, are terrified, are trying to get through the day, are trying to process what's going on for themselves and their loved ones. And there's a lot of sadness and fear and worry and disbelief. And that is a lot to process. And so again, we meet people where they're at. And part of this comes back to, originally, I think we started acknowledging the Being Mortal book, which I think a lot of you have probably read. So Tulgawande very beautifully sort of chronicles how he went around following palliative care doctors and geriatricians and hospice nurses and kind of dissected what questions did they ask that helped elicit some of these things. And so, we have almost a structured approach or framework to think about how to have these conversations. And we teach that as well, because we're at the medical school, we have residents around as well as our colleagues. And it's really about first asking permission to talk about the big picture, and then asking what do they understand about their health, so that you, as the either the clinician or the family member can kind of understand what they understand about the facts, but also emotionally, do they understand how serious this is or not? Because then that helps you know where they're at, and then to decide how much to share, depending on the situation. And then asking a lot of questions about what are you worried about? What are you, what's scared, what are your fears? But also, what are your hopes? What are you hoping for? And what makes you happy? And when you face other hardships in your life, what gives you strength? And how much does your family know about your hopes, worries, fears? And what are the trade-offs of things you'd want to go through or not? This gets back to your CPR point in terms of, amount of time versus quality of time. And then, honestly, in following this kind of framework, once you sort of uncover those priorities of people, it almost kind of authentically hands up a plan of care. Meaning you have you've talked about sort of the medical realities and then talked about what matters most to that person, and then trying to make a recommendation or find a plan, a way forward that makes sense based on that person. And so following, and we don't always necessarily get through that entire conversation at each visit, but you can imagine that those different components over time create a more clear picture about how to find a way forward in a difficult situation. So that's not, sort of an easy, quick answer to say how do you help somebody confront something they don't want to confront. It's again about meeting people where they're at, trying to find out, unpack what they're hoping for and worried about, what they already understand, and then continuing to partner with them to help them face that with their loved ones. And when you get stuck, because I know you're a physician, I think, right?
Yeah.
Is call your palliative care team.
Okay.
The Honorary Choices site, like we were talking, has a lot of other conversation starters, like how do you make a plan, personal directive, it's nothing really scary. Like they can think about what's important, what makes it worth living for me, so things that you can actually use as a conversation piece.
I can pull that website up too.
And we do have healthcare proxy forms and personal directive forms if anybody wants a copy to take with you, but always we can share those. But thank you. Thank you for coming.
Thank you all for coming.
Thank you for a great conversation.
I would like to thank Dr. Jennifer Reed, Nancy, Shana, and Dr. Nakpal for leading this very valuable discussion. As you all know, this is part of the project, the community-wide reading project based on Dr. Atul Gawande's book. And the next program that's coming up this week on Thursday is the screening of the documentary being modeled, and that is on Thursday, November 7th at 5 o'clock. Hope to see you all there. Thank you.
Thank you.
Thank you.